Excellent. I can see one or two people still coming in, so I'll just wait 1 second before I start. Great. Good morning, everybody, and welcome to our latest behaviour change briefing event. My name is Anna Granger, and I'm one of the directors here at Claremont. Today, we're going to be focusing on the role that behaviour change can play in helping the NHS to reach its ambitious targets around the early diagnosis of cancer. As many of you will know, back in 2019, the NHS decided to make diagnosing cancer at an earlier stage one of its top priorities and set itself a goal of increasing the proportion of people diagnosed with cancer at stage 1 or 2 from around about 50% to 75% by 2028. Obviously, at that time, nobody had any inkling that just round the corner we would be hit by a global health pandemic, which would change the way we lived, worked, and behaved, and obviously send the NHS into turmoil as well. So the pandemic forced the NHS to shift its focus away from that early diagnosis goal for a short time. And 4 years later, the NHS is still trying to get back on track. While record numbers are now have either had cancer referrals or are having cancer treatment, the number of people who are having their cancer diagnosed at earlier stages has only increased by about 2% since before the pandemic. So there is still a mountain to climb in order to reach that target. We are going to need multiple strategies to help drive up early diagnosis and to give people a better chance of surviving cancer at an earlier stage. Today, we will be looking at the role that behaviour change can play in this and talking about how it can make a dent in this target. What can be done to encourage more people to respond more promptly to concerning symptoms and also to take part in screening. So just before I introduce our speakers, if you haven't done so already, please can I ask our attendees to introduce yourselves. Please use the chat function to do this and let us know your full name, where you work, and also what you're hoping to get out of this event. Please also be aware that we are recording today's session and a recording will be made available on our website following the session, and the link will be emailed to attendees afterwards. So now I would like to introduce you to our speakers. So first up, we'll be hearing from Claremont's MD, Ian Fannin. Quick wave from Ian. Hi there. Ian is going to be talking about some stats, facts and insights relating to what might be needed to shift the dial on early diagnosis. Ian will then be joined by Professor Joe Waller. Hi, Joe. Joe is Professor of Cancer Behavioural Science at Queen Mary's University, London. And Ian and Joe together will be reflecting on what has been learned in the last 5 years about what does and what doesn't work in terms of changing behaviour to support cancer prevention. Next up, we'll be hearing from Andy Glide, who is the Early Diagnosis Campaign Strategy Lead, I hope I got that right, at Bowel Cancer UK, and also our Strategy Director, Philippa Williams. Together, they will be giving a sneak preview on a new campaign, which is all about trying to encourage people who are experiencing potential bowel cancer symptoms to visit their GP at an earlier stage. This is a campaign that Bowel Cancer UK and Claremont have been working on together over the past year. Our final speaker will be one of Claremont's senior consultants, Emily Rayner. Hi, Emily. Emily will be sharing findings from some of the research we've done with the North East London Cancer Alliance, trying to understand the barriers to cancer awareness and screening among people from the Eastern European community. Our speakers will then all come back together for a panel discussion at the end, and at that point they'll be joined by Caroline Cook, who is the programme lead for early diagnosis at the North East London Cancer Alliance. We will do our best at that point to answer as many questions as we can. There's also an opportunity to ask questions in the Q&A section as well, and speakers will be looking at those following their presentations. So please do post your questions there. So without further ado, I'm going to ask all our speakers, apart from Ian, to switch off their cameras, and I will hand over to Ian for our first session. Thanks, Ian.
Thanks, Anna. Give me a moment while I open up my presentation. Is that coming through okay? I'm assuming it is. Thank you. And in preparing for today, I've enjoyed a little trip back in time, actually, reflecting on all the work that we've done over the last 5 years since the NHS set itself its ambitious targets for early diagnosis of cancer as part of its long-term plan. So I will do my best to do justice to that work in the next 10 minutes. Let's start with what the NHS Cancer Programme's stated priorities are. Those are to improve cancer services, to diagnose cancer earlier, and to improve the experience of cancer patients. And for the purposes of the day, we're going to focus on the second of these, specifically the ambition to diagnose 75% of cancers at stage 1 and 2 by 2028. Obviously, the reason for that goal is that diagnosing at those earlier stages can have a big impact on survival. So the charts on this slide are the first of a few I'm going to steal from a recent presentation from Professor Peter Johnson, who is the National Clinical Director for Cancer. They illustrate just how bold an ambition this was. The one on the right shows how there was next to no movement in the number of cancers diagnosed early in the 6 years leading up to 2019, staying stubbornly static around the sort of 54 to 55% mark. And on the left, you can see that this has historically been much worse for some cancers. For example, cancer of the pancreas, esophagus, and lung, while other forms of cancer perform better, breast, skin, and thyroid, for example. The long-term plan was announced in 2019, but you, as Anna sort of suggested, you won't be surprised to see that the COVID pandemic made matters considerably worse for a time. So the long-term plan clearly was off to a terrible start in that respect. There has since been signs of some progress, though, with early stage diagnosis representing around 58% of cases by May 2023. This does appear to have been driven in part by increased referrals. So the blue line here shows how between August 22 and July 23, suspected cancer referrals were up significantly compared to pre-pandemic levels. But in spite of this progress, the fact remains that only a few percentage points have been gained in the 5 years since the long-term plan ambition was set, and there are less than 5 years remaining. So this clearly begs the question, can the NHS realistically get to 75% by 2028, and if so, how? Now, this slide is one that Peter Johnson shared recently that sets out the interventions that the NHS is investing in to close this gap and the relative contribution each of them are estimated to make in doing so. The early diagnosis strategy from the NHS is focused on timely presentation, improving referral pathways, targeted interventions using risk-stratified case finding, improving screening uptake, and investing in innovation, including new technologies and tests. And note also that comment at the bottom of this slide about the 8 to 9% gap between the most and least deprived areas. It's clearly, for the NHS, not enough to lift the average to 75% if that leaves some lagging far behind. So to today's exam question, is behaviour change communications the answer? Or perhaps more accurately, how big a part of the answer is it? So if we look at the work that Claremont has been doing in recent years alone, we can see the extent to which behaviour change has a role to play. So if we begin with supporting timely presentation, for example, we worked with North Central London Cancer Alliance on a post-COVID recovery campaign in 2020 to encourage people to present to primary care in response to symptoms, which aligned with the national NHS Help Us Help You campaign, which has been a significant investment for the NHS over a number of years now. It's clear that that national campaign has made an impact in terms of driving in broad awareness, but our view is it really does need supporting with consistent, localised work with stakeholders and influencers within communities in this way to really drive behaviour change. And Andy and Philippa will also talk about the work we've done with Bowel Cancer UK to support earlier presentation. And the work we've done with North East London Cancer Alliance as well, that Emily's going to talk about, also plays into this to some extent, as well as supporting screening. And I think it's fair to say most of the focus around earlier presentation has largely been around symptoms awareness and motivating individuals to act in response to them. And that's where the focus for behaviour change has been. But there is also an underappreciated need, I think, for the NHS and others to consider what it can do to remove friction in the patient experience to make timely presentation easier for people. If we look at referral pathways, Claremont is currently working with behavioural scientist Christian von Wagner, who I know is going to be on this call from UCL, to develop a behavioural intervention around the role of community pharmacists in driving referrals of suspected cancer cases to GPs. We're actually looking for funding for this, so we're open to suggestions here if anyone wants to follow up after today's event. We also supported the COCO study, which was led by Katrina Whitaker at the University of Surrey alongside Georgia Black, which showed that changes made to the colorectal cancer pathway during the pandemic, particularly the move to digital first triage in primary care, which persists to this day, caused a range of unintended consequences and exacerbated health inequalities. And so, it's clear that behaviour change in this space is likely to be mainly around the actions of professionals and policymakers. And in a complex system where opportunities for diagnosis can be missed or delayed at multiple stages, there's undoubtedly more to be done to ensure these pathways are working as well as possible. And I was struck actually yesterday, I don't know if people saw the news, that there was new research that showed that people from ethnic minorities and young people need more visits to the GP before being referred for a possible cancer diagnosis, and that those from more deprived areas are also 21% less likely to be referred for suspected cancer than those from the least deprived areas. And clearly that's likely to relate to the fact that there are fewer GPs per patient in more deprived areas and appointment times are shorter. And so these are systemic issues with no quick fixes. That goes well beyond motivating individuals to behave differently. On targeted lung health checks, Claremont is again working with North Central London Cancer Alliance, has been for about a year now, to support this programme. We're also aware that there's very similar work being replicated right across the country to encourage the at-risk population, mainly smokers and ex-smokers, to respond to invitations to attend these checks. And we were also very privileged to have supported recruitment to the Summit study from 2018 to 2020, which was a collaboration between UCLH, UCL and Grail. And it was the largest lung screening study of its kind in the UK, which helped make the case for the targeted lung health check programme, as well as supporting research on the Gallery blood test, and more on that one in a moment. In relation to targeted interventions aimed at high-risk populations, we supported a really interesting project led by Rohini Sharma and her team at Imperial College London to design a new liver surveillance programme in London aimed at those at high risk of liver cancer. We work with charity partners in London representing at-risk groups and help co-design invitation materials and other communications to maximise uptake. But most of Claremont's work, actually, in terms of this range of interventions, has been focused on improving uptake for the NHS's existing 3 national cancer screening programmes for bowel, breast and cervical cancer. This includes the project with North East London Cancer Alliance, as well as some of the other projects we've done with North Central London Cancer Alliance, such as one we've just begun, actually, which is exploring barriers for those experiencing homelessness in attending screening. We also worked with Joe's Trust to do some qual and quant research to understand how barriers to screening uptake may have changed immediately in the wake of the pandemic. And we were also proud to support the Youth Screen study, which was led by King's College London, which tested the feasibility of implementing HPV self-sampling for non-attenders to improve uptake within the cervical screening programme in England. And last but not least is the Grail's Gallery blood test, which is designed to detect a wide range of cancers before symptoms appear. Since 2021, Claremont has been supporting recruitment and retention to the NHS Gallery trial, which is the largest trial of its kind anywhere in the world, which aims to evaluate the impact the test can have in diagnosing cancers earlier when used alongside the NHS's existing screening programmes. We work with Grail as well as Joe Waller, Peter Cini and others at King's to use behavioural insight in the planning of the trial, undertaking research to understand potential barriers and motivations relevant to increasing invitation uptake. And this included understanding the different needs of those from more deprived and ethnic minority backgrounds who are typically underrepresented in medical research. And we're now actually continuing to develop this insight further as we work directly with North Central London Cancer Alliance again, and also RM partners, their West London equivalent, to help them consider communications plans for the multi-cancer blood test programme, which is an implementation pilot that's being considered by NHS England from this summer, which, if it goes ahead, will involve 1 million people aged over 55 being invited to take part. And this would be the precursor to a potential initial national screening programme. And it's clear this could involve substantial behaviour change, both for the public and health professionals, for this to be implemented successfully. So reflecting on all of the insight we've gained from these programs, there are a few common themes that rise to the top for me. Firstly, if we think about the COM-B behavioural framework, which looks at capability, opportunity and motivation, where does attention need to be paid? So we might assume that most people are capable of attending screening and will be motivated to do so, but it's clear that there are bigger barriers for those from underrepresented groups. Health literacy and basic cancer awareness remains a problem for some groups. For example, Emily will touch on this in relation to Eastern European communities. And there are greater issues with fear and fatalism among more deprived communities. Capability is also a key challenge for symptom awareness and attribution, and I know Andy and Philippa will cover this a bit in their talk. So to address both capability and motivation challenges, we've consistently seen that working with trusted community influencers is critical to delivering important messages effectively. So top-down national campaigns will always struggle to influence change unless coupled with targeted localized interventions and partnerships, with both ideally being co-designed with people representative of the target audiences. We've said before that the O in COM-B is often paid too little attention, and I suspect the same is true when you look at where investment in tackling this issue is focused. There's a lot of time and money going into achieving relatively marginal shifts in public behaviour, but is the equivalent focus being spent considering how the system could be changed to make the optimum behaviour easier? There are, I think, some bright spots where you can see this is happening. I mean, HPV self-sampling that I mentioned earlier, and the introduction of fit tests in primary care settings are really good examples of that. But I do wonder if more could be done to examine the friction in the screening system and understand where opportunities to encourage symptom presentation are currently being missed. Another observation is that the NHS is banking clearly on tech innovation to deliver significant gains, not just the Gallery test, but other innovations like the cytosponge test for esophageal cancer, and the use of AI and machine learning in improving diagnostics. But none of these technologies can be adopted successfully without behaviour change, either of the public or professionals or both. So building behavioural insight and communications into these programmes early, I think, is crucial. And the final, perhaps sobering reflection, we've begun to see evidence through our work that there's a very real risk that predicted gains across all of these programmes could be harder to realise in the context of an NHS that is struggling. As people lose trust and confidence that they can get a GP appointment, and that they'll be diagnosed and treated quickly if a referral is made, I think motivation to attend screening or present with symptoms could wane, especially among those who may already have fatalistic tendencies. Humans fundamentally dislike uncertainty, and some will be reluctant to invite that uncertainty into their lives if they lack confidence that it's likely to be resolved quickly. So this might not stop people taking action altogether, but I think it could harm efforts to encourage timely presentation. So returning to our exam question, is behaviour change communications the answer to the early diagnosis of cancer? You won't be surprised to hear that my verdict is a big fat yes. So if we assume Claremont's contribution is but a fraction of the behaviour change communications work taking place to support the NHS's efforts to deliver on its ambitious programme, it's clear that behaviour change is in fact already a big part of the answer. But I think there's also a really strong case that future investment into behaviour change communications has to be commensurate with that critical role. So that's the end of my presentation. I'm going to end show, and I'd like to invite Joe Waller now to turn camera on and join me, and perhaps kind of pick up on some of those themes. So Joe, you're one of the leading behavioural scientists specialising in cancer in the UK. What stands out for you from the last 5 years as highlights in the way that behavioural science has already contributed to the early diagnosis of cancer?
Yeah, thanks, Ian, and great presentation, really, and useful to have that sort of overview and insight of lots of things that have been going on over the last 5 years. I mean, there's lots to pick out. I'd absolutely agree with your observation that perhaps the sort of opportunity aspect of the COM-B is something that we've neglected, or paid less attention. And I think lots of work historically that health psychologists like myself have been doing is all about trying to think about the messages and the sort of theoretically driven way that we might communicate with people, particularly about screening, and how that might shift behaviour. And I think over the last 5 years, the work that I've been doing with Laura Marlowe in the cervical screening space has sort of, I guess, given us a bit of a reality check as to how much change one can affect by simply changing the messages. And we've worked with Anna from Claremont to develop an infographic to sort of incorporate lots of really evidence-based messaging about cervical screening targeted at older women. We found, we can achieve a very small shift in intentions, which may or may not be translated into behaviour if it were implemented. So it's clearly not just about that. And I think there are sort of large-scale things that we can do that will have a very small impact, but then probably the bigger impact comes from smaller scale, much more targeted and much more intensive sort of interventions with particular communities. But I guess one other sort of example to touch on from recent years is, obviously you mentioned the targeted lung health check being implemented, and I think the work that Sammy Quaife and colleagues did in the context of Summit was really important, trying to develop, again, target what we knew to be the barriers to lung screening. And we know that lung screening is a classic example of the people who attend are the people who need it least, and the group that are most at risk are least likely to attend for screening. And Sammy's work had obviously identified that stigma played a big role in that, fatalistic beliefs about lung cancer not being treatable, so there's no point in picking it up early. People in deprived communities where lung cancer is more prevalent are much likely to have witnessed that happening among people they know. So sort of targeting those specific things, calling it a lung health check rather than a lung screening program.
That was a key thing, wasn't it?
To just avoid that sort of fear response. But then I think so that's all great in terms of thinking about the way that the program's communicated. But then another example of a more from the COM-B model approach is, I know that in Southeast London they've been trialling offering people Oyster cards to get over that financial barrier of actually attending for lung screening. And it hasn't been evaluated yet. I think we can watch this space on that one. But I think thinking both about that, as you talked about, the motivational aspects and whether people want to attend or take part in these things, but then also how can we reduce that friction. I think we tend to think that in the NHS it's free at the point of care, so there's no financial barriers, but of course people on 0 hours contracts or people having to travel in London, and we see this in the work we're doing at the moment on the lung cancer treatment pathways, people having to spend huge amounts of money to get taxis to the centre where they've got to go for treatment. And of course, that's really difficult for people.
Can I put the big question I posed at the start to you? Do you think the NHS can achieve its 2028 targets?
I don't know as the answer to that. I think, I mean, it was interesting to see how that was broken down, and I'd be interested to see what was underpinning those estimates about how much impact the different things are going to make. A lot from that rides on the outcome of the NHS Gallery trial, and we won't know that for a while. I think that poses, there's an exciting opportunity if that's shown to really make a step change in early diagnosis. Then there's potential that could make a dent in in the gap that we need to achieve. We know that most cancers are not detected through screening at the moment, and so even if we increase the uptake of screening, that's, as that diagram showed, going to have a relatively modest impact. But I think, and I guess symptomatic presentation is the other thing that we've sort of touched on, that and it's so difficult. I mean, there was a recent evaluation of all of, I think, 11 Be Clear on Cancer campaigns to see what sort of impact is that having. And it's clear that it does raise awareness. It does increase the number of people going into primary care with those symptoms. It does increase onward referrals. But then as you move further down the pathway, the impact is less clear. So in terms of actually achieving earlier diagnosis and certainly better survival outcomes, it's harder to evaluate at that level, and it's harder to know what the impact is. But that's the key. Most people present with symptoms. That's how they're diagnosed, and so that's how to get people to recognise that things are worth presenting with. And I think the more sort of insidious a symptom is, some of the work Katrina Whitaker's done has shown people just adjust. We have this capacity to just adjust to new things if the onset was slow and gradual, and she interviewed people who were just dealing with the most appalling symptoms, but because it hadn't just suddenly gone in like that, they'd got used to it, they hadn't thought it was worth seeking help for. And so how we sort of overcome that human tendency to just be stoical, and actually, you know, get people to recognize what's important, and then GPs as well.
You mentioned Katrina. We worked with Katrina and Georgia Black in the early stages of planning the Bowel Cancer UK campaign that Andy and Philippa will talk about. And I really remember, it's really stuck with me, the advice that Georgia gave us, which was that awareness of symptoms is only half the problem. It's the attribution of those symptoms to potential cancer that is the real challenge for people, because you can be aware that a cough that persists could be cancer, but it could also be a number of other things. And we forget, I think, when we're doing these kind of awareness campaigns, the complex sort of context within which people are experiencing these symptoms, and as you say, how quickly people can adjust and write it off as something else. But also GPs do that clearly too, because as that research I mentioned earlier showed yesterday, you know, people are having to make repeat visits to GPs, and in some cases people are having to do that far more than others. And so it does feel like there are opportunities there to make a dent in early diagnosis, but it's certainly not simple.
And of course GPs have got an impossible job, and as have you know, all of us, because in most cases a cough won't be lung cancer, and so finding that needle in the haystack. And I think, I mean, there's really interesting work on GP gut feeling as a you know, something that's actually quite predictive of cancer risk, but really hard to pin down what that's based on. And I was struck, I saw the same report yesterday, struck by the fact that, of course, for young people it kind of makes sense that it would take longer to get referred, because of course the risk of cancer is so much less in younger people. It's much less acceptable or justifiable if it's ethnic minorities and people from more deprived backgrounds. But your point about resource is obviously really important there. But also, I guess there's the potential that gut feeling comes from a sort of difficult, you know, it comes from experience, it comes from knowing patients, and perhaps you know, if most of GPs' experiences with people from white backgrounds, that sort of creates biases in the way that they develop those gut feelings about particular groups, and that may also be contributing to differences in onward referral. But it's the needle in the haystack thing is really a difficult problem.
So can I finish by asking you to reflect on the other question I posed in my presentation? Is behaviour change communications the answer? What do you think? How big a contribution do you think that behavioural science and behaviour change communications can make to this area? And do you think it's recognised enough for its part in the solution, for example, versus, you know, technological solutions?
Yeah, I mean, I think it's both. And obviously, I mean, I'm always writing grant applications where I'm, you know, saying it's all very well having a sparkly new test or a vaccination, but if people don't do it, it's, you know, it's going to have no impact at all. So, of course, behaviour is a huge part of how we address this issue. And I think, I mean, some sort of positive examples, and it does feel like maybe it's being recognised more that this needs to be built in from the beginning. So credit to Grail for funding my group to do work looking at the sort of psychological and uptake aspects of a multi-cancer early detection test at the same time as evaluating the test. So we're doing work led by Laura Marlowe, where we're trying to understand, you know, in the community, what are the attitudes towards this kind of testing, what might be the barriers, and we're finding, like you mentioned, one of the things is that people are sort of skeptical about how this could possibly be implemented into a stretched NHS, and you know, the worst outcome is to get an abnormal result which can't be followed up because there's no way you can get a hospital appointment, and you know, that sort of concern. But generally a lot of excitement about a simple blood test that can potentially identify lots of different cancers. So but building in that work to understand the barriers, the potential inequalities, and also the psychological outcomes in people once they've had those tests and results, and how we can mitigate any sort of adverse psychological response is really important. And Cancer Research UK have also just funded us to do some similar sort of work with the capsule sponge test, the cytosponge in esophageal cancer, because again, it's we need to understand not everyone wants to swallow a capsule on a string and do that test, but with any new technology there's the potential to widen social inequalities if we don't understand which are the groups who might be more resistant or less willing to undertake it. So I think behavioural science is crucial to all of this. Of course, I'm going to say there should be more funding for it, but I think there is increasing recognition that it's not just about developing the technology. It's also about evaluating attitudes and acceptability and psychological impact as well as health impact, and clearly sort of interdisciplinary teams and multidisciplinary working on these issues is really the best way of doing that, rather than us all working in our silos and collaborating.
Agree. Well, thank you, Joe. Really appreciate it. I know you'll join us again for the panel discussion at the end, so we'll look forward to further questions and conversation there. But otherwise, hand back to Anna at this point.
Brilliant. Thank you very much, Joe and Ian. That was a really interesting session. I think there's a lot of food for thought for all of us there. Ian and Joe will be taking questions at the end in our panel discussion. If you do have any questions, please do post them in the Q&A. I have seen on the chat some people may have been having some technical issues reaching the chat. If that is the case for you, sorry, the Q&A, if that is the case for you, please put your questions in the chat and we will pick them up from there instead. So now we will hand over to Andy and Philippa, who will be talking to us about the new Bowel Cancer UK campaign. Thank you.
Thank you very much, Anna. Hello, everybody. My name's Philippa Williams. I'm Strategy Director at Claremont. Over the past a little over 12 months, we have had the absolute privilege of working with our colleagues at Bowel Cancer UK to develop a campaign that is aimed at encouraging people who are experiencing symptoms to get to the GP and ask for a fit test. I'm going to hand over to Andy, who's going to talk a little bit about the organisational strategic direction, and then we'll get into the thinking and what it is that we've created. I'm just going to share my slides now seamlessly.
While Philippa's doing that, hi everybody, nice to see you all. Thank you to Claremont for having me on this morning. I'm early diagnosis campaign strategy lead here at Bowel Cancer UK, and my first slide, which will appear any second now, we'll be talking about the challenge that we're trying to face here. So you already heard from Ian and Joe about the importance of early diagnosis. We know that for cancer, and is probably starkest for bowel cancer. In fact, when we look at the evidence that when diagnosed at stage 1, we know that more than 9 in 10 people will survive bowel cancer, but that drops dramatically to less than 1 in 10 when diagnosed at stage 4. But unfortunately, at the moment, we're only diagnosing around 4 in 10 bowel cancers at either stage 1 or stage 2. So there is a big shift that we need to see. We do have some good tools available to us for bowel cancer. It's already been mentioned, screening's already been mentioned, but we also know that we need to do more on timely presentation of symptoms. It's certainly one key aspect across the pathway. But if we look at things like the International Cancer Benchmarking Partnership, we can see that the UK nations tend to have longer patient intervals, so from first symptom through to first GP appointment, than comparable countries that have better bowel cancer survival. And we know that the problems are quite deeply entrenched. They're not equal across society, and that some people are experiencing red flag cancer symptoms, including things like blood in their poo, and could be waiting almost as much as 6 months or more before contacting their GP, which can contribute to delays and contribute to later stage diagnosis. On to the next one. So as an organisation, we had a new strategy back in the summer, places early diagnosis at its heart, as you would expect. And for us, it was very much about thinking we do lots of really good work in that post-diagnosis space. So once someone's had a diagnosis of bowel cancer, but we wanted to do even more in the pre-diagnosis space, and how we can make sure that we're being relevant and visible to really support people through that journey towards a diagnosis. And within that, then we have been thinking about kind of who we most need to reach. And again, there'll be no surprises here from everything that we've heard already. We need to tackle health inequalities. We need to reach those underserved communities. We need to be thinking about deprivation and ethnicity, where we've seen there are unfair inequalities that are being driven through the way that we currently operate, and we need to do that differently. go on to the next slide. We also did some thinking then around how we can do more in that pre-diagnosis space and what our theory for change would be. And as you can see, there are lots of blobs on here. I'm not going to go through each and every one, but what's really pleasing is that we wanted to build this behaviour change campaign that wasn't acting in isolation, but actually has a thread all the way through all of our work. And we're doing stuff in the sort of pre-symptomatic space. You might have seen we've got a new partnership with Andrex that really tackles embarrassment. We're coming towards the end of Bowel Cancer Awareness Month, where we've been doing some really good engagement work to help raise awareness of bowel cancer and the symptoms and other aspects too. We are supporting people to have really in-depth conversations through our roadshows and our awareness program that's going on right now, all the way through to supporting primary care and thinking about the sort of wider system changes that need to happen, all of which is underpinned by our really high quality health information, our peer support services, and our research funding as well. And as you can see, you know, we can see what putting all of those together could deliver for us in terms of impact. And actually, if we start thinking about this from an individual's point of view, you can start to see how there are lots and lots of opportunities for us as a charity to touch people's lives and really make a difference, start chipping away at some of the barriers that we know exist for early diagnosis. I'm going to hand over to Philippa for a few slides now.
Thanks, Andy. So where did we begin our journey? We started off looking at the secondary literature, and really focusing in on what the research was telling us in terms of why people who experience signs and symptoms don't present to their GP. And we use the COM-B model that many of you will be familiar with to sort of analyse that thinking. And touching on lots of what Ian and talked about just now, we saw that there were absolutely kind of capability barriers around symptom awareness and health literacy. There was a lot within that kind of motivation space. So fear of the test, but also fear of the outcome. Embarrassment. So when you're talking about poo, when you're talking about blood in your poo, when you're talking about changes in poo, that often there's quite interesting research that shows that they're often the things that people talk about at the end of their GP appointment, and therefore can be things that can get lost. And obviously when you're talking about poo, there's kind of that innate fecal disgust that can come through. And also this sense of kind of fatalism, which we know is more prevalent within lower socioeconomic groups, where people are more likely to have knocked into or have experience of others who have had negative outcomes. And then the opportunity barriers, which we'll come on to talk about later, but I think we've seen in so much of our work at the moment is this perception of not wanting to waste the GP time. You know, NHS is overloaded, but also this challenge of, will I be able to get an appointment, and will I be able to get through the kind of conversations with the secretary and then into actually seeing someone. So lots of barriers, and the first thing that we sort of did was try and organise them into kind of chunks. And then we asked ourselves the question as to, well, what of these barriers can a behaviour change campaign address, and what are the barriers that Bowel Cancer UK should be addressing, what's within their capability. The process that we worked through to get there was we created a co-design group with people who've had experience of living with bowel cancer. That was really important to kind of keep the authenticity of the work, but also did multiple qualitative focus groups where we spoke to people from Southeast Asian backgrounds, Black Caribbean, Black British, Black African backgrounds, and White British backgrounds with a CTDE socioeconomic lens. But also we split those groups by gender because we had a sense that we may get stronger insights within gender groups. We also spoke to academics working within the field, as Ian mentioned earlier. So Katrina Whitaker and Georgia Black were really kind enough to give us their time. And through distilling all of that insight and work, we sort of came to, I guess a sort of process in terms of when these barriers kick in. So initially it's around encouraging people to understand and recognise their symptoms as potentially serious, but then the importance of giving people a threshold, a moment in which they know that they need to act, and that allows them to give them sort of permission to go to the GP. And then acknowledging that it's at that point that those fears, embarrassment, fatalism tend to kick in. And based on all of that insight, we then got to a point of redefining the barriers. So low awareness, attribution to cancer, fear, fatalism, embarrassment, and then ease of access to the GP. So our strategy became, if our audience is feeling confused, scared, worried, and embarrassed, that can lead to inaction, which we can inadvertently amplify. And in our groups, we tested a number of different creative STEM, a lot of which was around a line that was, get checked quickly, rule out bowel cancer fast. Which seems quite a kind of light line in reality, but what it did to our audience, rather than motivating them to act, it made them feel more scared. It made them feel more apprehensive. It made them feel more nervous about going and getting tested. And going back to what Ian was talking about earlier about that, we are, as human beings, we like consistency within our lives, and this sense of, something being chucked in that would be scary, that would induce fear, really push people away. And we saw almost like a physical reaction to that level, that type of creative within the groups. So where we got to in terms of strategic direction was that actually what the work needed to do was provide clarity. So it needed to solve a problem, not create a new one. It needed to provide reassurance, so reduce that fear of the unknown and give people an invitation or permission to act, give them hope, the personal benefit of acting, and acknowledgement of the discomfort that they're experiencing, but also of the individual themselves. And what that meant in practice was clarity was about what to notice, when to go, what to say, what to do, how to do it, and to use language that people would use themselves. So plain English in this context, that's about talking about poo, talking about diarrhea and constipation, about using language other people would. Providing reassurance, and that was really focusing in on the fit test, so the at-home poo test that you can ask your GP for, and using that as a way of demonstrating that it is easy, it's simple, you can do it at home, you don't have to do it in front of your GP, it's not going to be an invasive procedure, that it probably isn't cancer, but it is worthy of action, and you are worthy of action. And hope, there's a lot of hope within the bowel cancer space. There is a test, there is treatment, and it is treatable if caught early. And those messages were really important within this space. And then acknowledgement of who you are as an individual, so representation, and also how you're feeling. And I think it's important to note, because that can feel like, gosh, how do you get all of that in a campaign, right? But a lot of what we're talking about is, some of this is about the creative treatment, that it's a campaign that feels warm, that feels safe. And some of it is about the messaging in your initial campaign moment, but also the messaging that sits in the onward journey. So on the Bowel Cancer UK website, for example. I wanted to include this here, particularly for this audience, because we did spend a lot of time debating about cancer and how much we wanted to include cancer within the campaign. We kind of tested it. We tested its prevalence. We tested its positioning within the creative. And I think where we got to is that it was important to talk about cancer, but that the line needed to, because it brought a kind of sense of urgency, but it had to be pillowed with hope. So probably not cancer, but it's important to check, and it's treatable if found early. And then in terms of an output was this comprehensive messaging matrix. Get to the bottom of it is not the final line, but it was an organising thought, I think, about helping people to say, something's not right, get to the bottom of it, find out what the matter is. The one thing that I just wanted to really focus on here is the importance of the test. So we talked about some of those capability barriers before, and the test really was our shortcut of saying this is an easy process, and that played really well within our groups. Andy, I'll hand back to you now to talk about how we then took the strategy into action.
Thanks, Philippa. So yeah, the next stage was very much to see how we could deliver this campaign message, and together with Claremont, we worked with another agency, Yonder Media, to develop our media strategy. And this is a chart that probably looks a bit strange, but the way to think about it are the green blobs are when a campaign is live, where that line then is sort of, almost think about it as sort of awareness recall of campaign, and then we could probably track along just underneath it probably action that people will take. Now, where we landed very much based on the strategy that Claremont had helped deliver for us, is that we needed to do something different from more traditional cancer campaigns like Be Clear on Cancer and others that are delivered by the charity sector and NHS colleagues. Normally, they tend to happen within a very short 4 to 6 week burst of activity, lots and lots of stuff going on all in one go. And if we were going to plot the same thing on here, we would see a much higher peak of that line, but it would tail off immediately afterwards, and the effect wouldn't be sustained over time. And that tends to be, that is very much reflected in the evidence and evaluations of those sorts of campaigns. What we've landed on instead is this idea of a pulsing campaign rather than a big burst. So as you can see, each of those green blobs tends to be happening every 2 weeks with a couple of gaps. So the campaign will be on a 2 week on, 2 week off approach, which we think will have lots of benefits. So while we won't see that big same peak, we will see smaller peaks, but we think they'll be more sustained as a result. So we can keep tapping away at that messaging, chipping away at those more quite deeply entrenched barriers that we know exist for some parts of society, and really target those communities really effectively. This approach rules out ever being able to do anything with TV because the budgets would just be ridiculous. And what that's meant is that's really focused our minds on which locations we need to be in and how we reach that. The added benefit of this is then that we think, our hypothesis is this will have less pressure on primary care as well, because we're not driving all of that traffic into primary care in a very short space of time. It will be a cumulative effect, and it will take some time. We think the message will need to be seen several times, particularly for some of those communities, before it starts to land and before they start to recognise they have symptoms and recognising the need to take action. So this will be a different campaign. We'll see how well it works. We'll be monitoring it really closely, but we're quite excited that we think we might have landed on something that can deliver a really effective behaviour change approach. Before we go on to the next slide, oh no, there it is. Can I just ask we don't screenshot the next one? They are a very quick sneak peek of exactly what the creative is going to look like, but it's all going live a week on Monday, so you'll hopefully be able to see it on the web. Then we can now go on to it, and you can see kind of how it's evolved. So as Philippa said, we've evolved away from get to the bottom of it as our kind of main approach. The key line is now about tell your GP instead, and what we're doing is we're putting symptoms, conversations into unusual settings. So you can see there's someone talking to their cat, there's someone talking at the supermarket or to their plumber about the fact that they're experiencing a symptom, and then with a clear line and a clear call to action of tell your GP instead, ask for a simple at-home test. We all know that to be fit, but again, through our testing, both with Claremont and then through the creative development further on, we know people like the idea of fit, they don't like the medical language around it, so it's much better to be talking about it this way, and there's a little bit more information, and you can see that pillowing of language there around, that it's probably nothing to worry about, but it's worth making sure bowel cancer is treatable when found early. And again, you can see, while the creative has evolved, it very much is still the foundations of the work that we did with Claremont is all the way through. And then how we're delivering this is through a lot of out of home, which are going to be targeted in particular locations where we think there are high numbers of our target audiences. And we've been thinking about attitudes in terms of audiences before demographics. So thinking about people who have quite stoic attitudes, quite fatalistic attitudes, as well as people quite skeptical of healthcare as well. And then when we overlay demographics onto that, then we can start to see exactly where we think these people will be. We're doing some really good work with a couple of South Asian radio stations in partnership with them to use their voices to deliver this message in a way that hopefully will make it a much more trusted message than will coming just from Bowel Cancer UK. But there'll also be adverts going on local radio as well, so it feels very, very personal message all the way through. And then we're also doing some digital work as well, and that's in a slightly different territory in that we know that people will have self-diagnosis behaviors in some cases. They'll go online, they'll go to Google, they're probably going to find something that tells them they don't need to worry about the GP to reassure them too much, kind of thinking about that urgency and hope balance that we're trying to reach. And so our adverts will be sort of, again, directing them towards the need to speak to their GP and ask for that at-home test. Going on to the next slide, another piece of work we did with Claremont that went alongside this was to think about our user journeys around the campaign. So obviously when someone sees the campaign, the ideal situation would be that if they recognise that they have symptoms themselves in that moment, the first thing they do is pick up the phone and book an appointment. But we know that that's probably not going to be the case for the vast majority of people, and particularly for our target audiences who will still have additional information needs, questions, and we need to be out there to support them. And Claremont worked with us and looked through kind of how we're delivering some of those more supportive wraparound messages in different ways, and how we can improve that as well to make sure that then once someone sees the campaign, if the next step is I need to find out more information, the Bowel Cancer UK is there, and again constantly nudging them towards the GP so that we're reducing that delay that they might otherwise experience. And we've been putting some of this into practice already. So we've from recommendations based in some behavioural science, but we've also been looking at search engine optimization, SEO recommendations as well. And we're actually already seeing the benefit of that in terms of some of our web traffic, even before the campaign goes live. So we're confident that we can be there and supporting people through what is quite a challenging time for them. Sorry, finally then, just to go over a couple of quick learnings. There's been a lot that we've learned over the last year, and we'll no doubt continue to do so. I think for us, really important that we don't see this campaign as being in isolation. You saw our theory of change and how it all fits together, and how, you know, those multiple interventions will hopefully, again, drive people to primary care in a more timely way than might otherwise be happening. We have a really singular focus. You saw on the creative that we showed you, and you'll see across the rest of it, there's very little that points you to Bowel Cancer UK as a call to action. It is all about seeing your GP and being really focused with that clear message and repeating that regularly, so that's really getting through to people. Testing has been so important through this, and with our target audiences, as Philippa mentioned, we've taken that through the creative development as well, with a very similar robust testing methodology, which has helped us get to the point that we've got to, which makes us feel really confident that actually we've got something that's going to work for these communities. The end-to-end journey stuff, which I've already talked about, you know, the importance of not just thinking again about the campaign, but the wider, you know, support that's available and how we can get people through that part of their journey. With the media plan, the importance of, you know, getting to people at the right time and thinking differently, being really targeted, and that's led us on to the pulsing approach that we're going to take. And finally, the creative, as you saw, aiming for that kind of hope, that reassurance and that warmth, in order to kind of tackle some of those barriers that people were feeling about cancer and fear and fatalism and the rest. And I think that's
it.
Thank you very much.
Brilliant. Thank you very much, Andy and Philippa. That was a really interesting session, and we look forward to seeing the new campaign live in the next few weeks. So I think there's already been some great questions put in the Q&A for Andy and Philippa. We'll be coming back to some of those in the panel discussion. I'm sure they'll be looking at some of them in the Q&A as well. Please do keep your questions coming. If you're still having technical problems with the Q&A, please put them in the chat function. So I'll now hand over to our final speaker for today. So Emily Rayner is now going to talk to you about some of the work we've done in North East London relating to the Eastern European community. Thanks, Emily.
Thanks, Anna. I'll just put up my slides. There we go. So we've been working with North East London Cancer Alliance. As many of you will know, this is one of 21 cancer alliances that are helping to improve diagnosis, treatment and care of cancer patients. And they came to us with a particular challenge around what is described as the white other audience. Again, as many of you will know, the ethnicity data available around screening uptake makes these very kind of broad categories, white British, black, Asian and white other. And they particularly wanted to find out more about that white other audience, because actually in many of the North East London boroughs, this makes up around 20% of the resident population. So it's a really important audience to try and understand better. They wanted to know who those people were, and also how better to communicate with them about signs and symptoms of cancer, and also about attending screenings. So a quick look at the data told us who was in that audience group within North East London. And I won't go through all of these, but you can see here some of the higher categories of individuals. And from there, we distilled that down to recommend that the focus be on Polish, Lithuanian, Romanian, Turkish and Turkish Cypriot. We did discuss the populous white Irish group, which you'll have seen in that list there was very high up. But our feeling between us was that the barriers might be quite similar to those of the white British residents, and therefore were not necessarily going to be part of the research at this stage. So we began by just doing some secondary research, so our desk research from lots of different articles and reviews, engagement with experts who we knew a lot about this audience, and then some of our work to date, which had involved looking at other minority and underserved audiences, many of whom you all have heard about in projects that we talked about already today. And then we used the COM-B model to look at kind of a broad overview of the sort of capability, opportunity and motivation barriers across those different groups that I mentioned. So within capability, we found that language barriers and access issues were prominent across all audience groups. For Turkish people, understanding of cancer causes and spotting symptoms were important issues for further exploration. In terms of opportunity, access to credible information in Polish and Romanian seemed to be problematic. And we could see from the literature that this might drive Polish people to actually go and have their healthcare needs met back in Poland. That's something we wanted to look at a bit more closely as well. And for Turkish communities, taboos and cultural barriers, particularly around female cancers, warranted further exploration as well. In terms of motivation, there was distrust and dissatisfaction across all groups. For Polish and Lithuanians, this was more tied to the NHS. For Romanians, this was tied to a distrust of the state more generally. And fatalism regarding cancer, something that we've heard about already today, also appeared across all of the audience groups. So it was then important to do our primary research. So we conducted street research with 362 residents across northeast London. We worked with a company called Kaizen, who are specialists engaging in this type of research on the street, using people who are from those communities, meeting people where they're at in parks, in shops, cafes and community centres, etc., and doing live translation where necessary to make sure that the conversation was properly captured. And our findings from Polish and Lithuanian audiences included those strong ties to home, as I was mentioning already. We thought that perhaps it would be worth looking at whether they would respond more positively to seeing Eastern European names and faces working within the NHS in any relevant communications. And a number of Polish people who we spoke to used the phrase better safe than sorry. And we thought this might be an interesting thing to test out as we do further research down the line. People told us about access issues, which actually we'd heard about in the primary research as well, and that came up in the conversations. Many suggested going further and utilising Polish social media groups and shops for outreach. That was something we wanted to look at too. Polish people who stopped were predominantly female, but those females did tell us that there was a lot of male resistance to cancer screening, and we felt that there was further research needed, particularly with men, to find out more about that. From the Romanian audiences, we found that friends and family were highly trusted, and we needed to think about how we could utilise them as messengers for any potential communications. People used the explanation that they didn't have time as a reason for not engaging with this, and that was something that also came out as perhaps an issue around language barriers and not properly understanding information when we delved a little bit deeper. Many said that they were healthy, and so they didn't feel that it was a risk for them and that they didn't need to go and get checked. And as I mentioned, there was a high distrust in government, and we thought that probably, therefore, wouldn't be wise to include the NHS in communications because that wasn't someone that they wanted. And finally, the findings for Turkish and Turkish Cypriot audiences in this stage of the research, we found that understandings of cancer causes and symptoms were important barriers, and our conversations indicated an awareness of cancer screening being low. Fear was also mentioned among this group, and we found that the role of the community was important. So we thought about whether we could utilise community organisations to deliver those messages. And although we didn't get to speak to a lot of Turkish Cypriots through this street research, we did hear from those we did speak to around Cypriot superstitions, particularly around cervical screening. And we really wanted to delve deeper into that to see what else we could find out. So we were then able to do focus groups across all of these different audiences, but I've only got time here to speak about the Polish community. So I'll give you a bit of an insight into what we did with them. and take you through to the kind of co-design process that we've done more recently with them as well. So we worked with the House of Polish and European Community. That was our community partner in this. And we worked with groups of men and women because we felt that sometimes it would be better to have those conversations separately. And we had people in the room to help us with translation as well. So there wasn't any barrier to communication for individuals who attended. And we spent time looking into some of the issues that I've discussed already in more detail, really trying to unpick those barriers and see what the differences were, particularly between men and women and older and younger audiences as well within this. And here are some of the key insights. I won't go through all of these, but I've got some slides to go on to that will give you some of those insights in more detail. But here are the things that this particular group, where it really came through strongly. So receiving screenings in Poland did seem easier. People talked about regularly going back. If they were seeing family and friends anyway, then they would go and get checked. It wasn't always necessarily checks that were the same as the screenings we were talking about. So, for example, someone mentioned prostate there, but generally getting their healthcare attended to when they were back in Poland was quite typical. There was a lot of distrust and frustration with the NHS and GPs in particular. In all groups, but particularly in this group, there were lots of complaints about how long it takes to see your doctor and how difficult it is once you're in there to kind of have to go over the same information again. And the fact that lots of the appointments are now online rather than face to face. This was not specific to this audience, but it definitely came out as a key frustration for them. As I've mentioned, men had a higher reluctance to get involved in screening than women. There was this sort of sense of being kind of strong and capable and it not really being something that they needed to engage with. It was seen as a weakness to go to the doctor and get checked out for things. The community setting that we were in was one of the places that was most in favour to carry on an intervention. So people said, you could come back here and you could talk to us here. We'd be happy to hear from a doctor who was a Polish doctor to give us a kind of more detailed conversation about screening. They did worry that perhaps they would normally be talking about more sort of fun and engaging things at an event like that, but they did see that there was space for something more serious as well. So we kind of concluded with them that there were kind of key recommendations for co-design and that should be in a community setting, be in the Polish language, that it was very important that they would see Polish names and faces if we featured someone working from the NHS. We wanted to highlight the cancer journey so that we could clarify that actually getting that kind of early screening was important to do that in the UK, as well as the sort of later cancer care that people did tell us was important to do in the UK as well. We wanted to share some fear-busting messaging, the ease of the test, the likelihood of it being non-cancerous, and include that phrase better safe than sorry that kept coming up. And as was mentioned in a previous presentation, using simplified language and the idea of a test, not a screen. I found in a lot of the research that I've been engaged with in this space that screening is not a word that people really understand. So we then went on to do our co-design activities. Here we are again with the same group. You can see some photos here of them looking at some stimulus of previous campaigns where we could get a sense from them about what they liked and what they didn't like. And we had a really vibrant, engaging conversation with those individuals about what it was that they wanted to see. And we presented them with different ideas that had come out through the conversations. One was to do a coffee morning at the community centre. One was to do more of a fringe event around a festival or something that was in the calendar for them already. Posters and flyers in familiar places. This coffee morning was actually in a local library, so that could have been somewhere that we could put some material. And then finally, video content shared with the community. And actually, that last one was found to be the most exciting for this group. They really felt that video content would help them to understand the different screenings, and it was something that was really shareable, something that was really digestible. And they really liked the idea that it would feature Polish people that looked and sounded like them. So it was really important that we had a high level of Polish involvement, cast and production, and that obviously therefore people were speaking in Polish, and that if people were listening without being able to listen to the audio, or they would just be able to watch the subtitles in Polish as well. Wanted it to be short and shareable, and to think about the shareability with trusted partners as well as friends and family. And they wanted it to kind of feel like it was replicating the face-to-face sessions that they had in their community setting. So thinking about the popular questions that they might ask if they were meeting with each other face-to-face. And I can't show the video because it's not yet been finalised, but here are some photos of it in action. It's really exciting to see it come together. So the doctor that's featured in here is Polish, as are the women who are participating, talking about their experiences of screening. And so, yeah, hopefully next time we get the opportunity to present this case study, we can show you the video and tell you a bit more about how that's been received within the community. And thanks to Caroline and colleagues, we also have the go-ahead to do some co-design with the Turkish and Turkish Cypriot groups as well. And that could be something completely different, not necessarily a video tool, could be something in the community, could be something attached to their festivals. But it'd be really exciting to see what we do next with them as well. Thank you.
Thank you very much, Emily. That was a really interesting session. Thank you for sharing all your insights there. So at this point, I'm now going to ask all of our speakers to turn their cameras back on for our panel discussion. Thank you to everybody who shared questions today. I can see there are quite a lot of those coming through. We'll get through as many of those as possible now. So I think there's been a couple of different questions to do with sort of GP relationship and the GP interaction. As Joe talked about earlier, that idea of sort of gut feeling is obviously very important in terms of GPs deciding whether to refer people or not. One of the questions we had today was around appointment times. Obviously, people can find it hard to see their GP. Appointment times can be very short, can be only sort of 5 minutes. Does that make a difference, do you think, in terms of how that relationship works and how easy it is for GPs to have that gut feeling that is needed? Joe, do you want to answer that, or is there anyone else who'd like to come in on that one?
I mean, I'm sure short appointments do have an impact, and also the tendency. I mean, I think things have really changed, so it's quite unusual now for people to always see the same GP. So that continuity of care isn't there, and people, don't necessarily have a GP who knows them and would notice that something just seemed a bit off with them, which might be the sort of thing that would raise suspicion. So yes, I think that's a really good point. And I don't know, the answer is obviously to do largely with the resource side of things, and there's not enough capacity in primary care at all, let alone trying to make appointments longer. So there's certainly not a simple answer to that, but I think it's a really good point.
Can I quickly add one of the things that on this that I've heard GPs talk about is that there's a thing they refer to as the Columbo effect. For those who are old enough to know the private detective Columbo, he used to always come into the room at the end and go, and one other thing. And in GPs, they would refer to this as something where someone has come in for another reason, and often a more a less concerning reason, and then towards the end of an appointment might go, actually there is one other thing that's bothering me, and that's when you would get these sort of more concerning symptoms be presented. And I think if you shorten the appointment, clearly that you are at risk of losing that effect happening. And I think there's no question that this is a problem. What really concerned me was the data that shows that these appointment times are shorter in more deprived areas. So not only are there fewer GPs per patient, but the appointment times are shorter. And as Joe said earlier, that's not really acceptable. That's something that we can't have maybe the perfect length of appointment and the perfect access to GPs universally across the country, but I think the NHS's attention really does need to be focused on that in terms of their workforce plan.
Great, thank you very much, Ian and Joe. So just sticking actually on the point of health inequalities, in trying to meet its early diagnosis targets, how can the NHS make sure that it's not actually inadvertently widening that health inequalities gap? Andy, do you want to answer that one, or Ian?
I mean, it's the million-dollar question, isn't it? It's such a hard one to do. I think this is where the importance of everything we talked about in terms of co-design, of testing, of really involving people trying to tackle bias, etc., is going to be key. I think we need to always have that laser focus on who is it we absolutely need to reach, and what's the best way to do that. And it's not an easy thing to do. I think we know that a lot of people working in this space aren't necessarily representative of the people that we need to reach either. So again, that's where, you know, inherent biases do come into this sort of thing. The mantra that I always use at Bowel Cancer UK is we are not target audience. So we're doing things that actually are quite different for us, and not the sort of things that we would probably suggest first off, but that's okay, because we're not the target audience. And even our campaign, you know, because it's not going to be on TV, because it's going to be very targeted in certain local areas, because it's going to be on South Asian radio, etc., we're probably not going to see it. And again, that's okay. You know, it is out there, it is doing good work, and hopefully having the impact we want it to have.
Excellent. Thank you very much, Andy. Now, I've got a question for Caroline now, actually. To what extent do you think that cancer alliances see behaviour change as being a significant part of the problem in terms of a significant part of the solution to early diagnosis?
Can't hear you, Caroline.
Caroline, we can't hear you. No, we can't at the moment.
No.
I'll come back to you, Caroline, with that question. I'll just move on to another question for now, and then I can come back to you in just a moment, and we can sort of try that again. Okay, so actually, I've got another question that, again, I think it relates to sort of the target audiences we're dealing with. A lot of the campaigns we're doing, of which there are a great number, are often targeting the same communities. How can we make sure that we're not overloading those communities and, you know, potentially actually watering down the messages by, you know, giving them so many different messages about maybe different types of cancer and that kind of thing? Ian, Joe, do you want to pick that one up?
Yeah, I answered this on the Q&A, so I'll try and sort of replay a little bit some of what I was saying. I think there's no question that when multiple campaigns are planned by multiple organisations, and they will often gravitate to the same audience groups, quite rightly a lot of the time, because the focus should be on those who need help most. I don't think that's a problem if those campaigns are supporting and reinforcing each other, and are drawing on best practice. So we always begin any project we do by looking at what's happened before, what works, not reinventing the wheel. And looking for those opportunities to amplify if there are existing other campaigns happening that people will see. So it's especially important. I mean, actually, we looked at this with the bowel cancer campaign. We were, you know, very cognizant that there was an existing NHS England campaign running nationally, Help Us Help You, that was referring to bowel cancer. So you've got to be cognizant. What space are they filling, and are we filling a space that's perhaps either complementing that by reinforcing the same messaging, or by addressing potentially a different barrier but making sure it's not conflicting. So I think, you know, it can be a good thing to hear from more sources, but yeah, that's the watch out. You've got to avoid it being conflicting or confusing.
And I think, can I just add to that? I think there's also opportunity within the screening programme. So we've been doing a little bit of work, sort of trying to understand, is there more, because the screening programmes operate quite separately, whereas there's a certain age group of women that are eligible for all three programmes, and we know that the uptake is inconsistent across them. So sort of thinking about a more joined up approach to potentially, if someone's at their mammogram and they're overdue for bowel screening, is there an opportunity there to give them a fit kit, which at the moment isn't something that could happen, but sort of trying to have a more, and sort of to give people a more sort of coherent sense of, these are all the things that I can do to reduce my risk of cancer, that includes the symptomatic messages and the different screening programs that they might be eligible for. So I think, yeah, there's obviously a risk with it bombarding people, but I think if it's thought through carefully, there's an opportunity there as well.
I know that the NHS in Scotland actually did a campaign that was really interesting, because they came to this conclusion that they were bombarding on lots of individual messages, and so they did a campaign that was about all forms of screening. And there was a TV ad they produced that that featured the different types of screening, and so there's this overarching message, which I think can be effective if you then have more targeted messaging to targeted groups underlying that. You've got to do a bit of both, because the risk of doing something that's so generic is it's not quite action oriented enough.
I just wanted to come here as well, Anna, of, like, I think it's a really important point, right, of, you know, you can get so focused within your lane and therefore not be able to kind of dial back. And I just think the other thing that I've seen across other work that I'm doing is that, you know, generally people at the moment are bombarded and feel like they are working and just trying to make ends meet and just trying to stay above water. And so I think the more that we can think about our work within the context of the other things that are going on in people's lives, like cost of living crisis, you know, huge childcare costs, you know, people just trying to make, you know, so therefore this point of like chucking in another problem. And so I think that's why so much of what we've been trying to talk about is give them a solution, give them a way of making things just feel a bit easier for them, not trying to just chuck a, you know, you might have cancer message in. You know, how am I possibly meant to deal with that when I've got all this other stuff going on for me? So yeah, it's just to kind of watch out that we don't get even just stuck within our cancer lane, that we can't see what else is going on for people.
Absolutely.
I think just to add one final thing is, like, building on what Ian said in his presentation at the start, the messenger is also really important here as well. You know, people will respond to an NHS campaign differently to a charity campaign, and we need to think about having different messages. Obviously within that, community leaders as well. You know, one of our thinking around having the South Asian radio partnerships is that, you know, for that community, Bowel Cancer UK is not relevant to them right now, but hearing that from their favourite presenters helps to build that trust and hopefully get that message through stronger. So I think there is the message does need to complement. We've been working really closely with CR UK because they're running a campaign right now in Wales to make sure that, you know, we're complementing each other, and actually independently we've come to a very similar sort of approach, which is also really interesting because they both were tested and went through quite a process. So yeah, it is that we do need to work together on it, but it's also okay, I think, for different people to be saying the same message in different ways, because a single campaign on its own can't solve this problem.
Great, thank you very much. Caroline, can we come back to you? Should we try your sound again?
Can you hear me?
We can hear you. Yes. Shall I just repeat the question again, just so we remember what the sort of context was? So the question was really about cancer alliances, and to what extent you see behaviour change being a significant part of the solution in terms of reaching those early diagnosis targets.
Right. Yeah, as I was saying, that's a really good question. And I think it's something that Cancer Alliances have started to think about a lot more. I know certainly with my colleagues in London we have. So I think it's absolutely key. But what's really important, as we've talked about, as everybody has talked about today, is actually really targeting that message. So I think improving, we can make sure that that screening services are accessible. We can make sure that people can see their GPs, although that, as we said, that's quite difficult sometimes. But what's really key is making sure people understand that it's important for them to act on their symptoms, or act on the call to actions that we've got. So I think it's about changing their health-seeking behaviours, as we've seen with the Polish population and the Turkish population. It's changing attitudes. So and there's the capacity and the means are there to diagnose people, but actually it's more about changing people's attitudes to their health and to what really matters. And I think a lot of the things that we've talked about, I think this question's kind of been answered in some ways as well. A lot of the things that we've talked about are making sure that we've got the messenger right. People are more likely to listen to friends and family, or listen to their faith leaders, listen to people that they trust rather than the NHS. And I think, as Andrew just said, there is a real difference, as we've seen, with if something's badged with the charity than it is with the NHS. So we've worked with the Eve appeal, and that's really helped, I think, to get people talking about postmenopausal bleeding. But it's very much about making sure that you're targeting people in the right way, and people can see themselves in the communications. If you can't see yourself, it's not in your language, all that kind of, you're not going to really engage with it. So I think that, and actually what we found in northeast London is we've started to really sort of target very small audiences. So for example, we'll be working with the Romani population next year, and as Emily has said, we'll be working with the Turkish and Turkish Cypriot population. And I think it needs to be at that level to really have that impact. So hopefully that answers the question.
Absolutely, that's great. Thank you very much, Caroline. So I'm now just going to come on to another question that's been asked in the Q&A. So the question is really about the balance between telling people that, you know, it's probably not cancer, giving them that reassurance, but also making them feel the urgency and the necessity to take action as well. So what is the best way to provide reassurance, but not in a way that's going to scare people and, you know, make them not want to do anything and maybe put off entirely? I don't know who would like to answer this question. Emily, do you want to take this one, or Andy?
Just really quickly, just to say, as Philippa sort of alluded to, it's a discussion we've had over the last year constantly on this one. You know, how do you balance that urgency and that hope? Because if you lean too much into one or the other, then you're going to have a negative effect. It is really difficult. I think for us at Bowel Cancer, you have a very positive message to be able to say in terms of early diagnosis, in terms of fit, in terms of, you know, that it is very treatable at early stages. And we think that that's going to work through. It certainly came through our test audiences, and I think, you know, that's not the case for every cancer either, unfortunately. So that will need a more nuanced message, but it's always balancing that, and I don't think there's a right answer necessarily.
I think the other thing to say about the campaign that we've worked on with Bowel Cancer UK is that we really consciously had a conversation early on about, is this about broad awareness of symptoms, or is, you know, are we talking to everyone, or are we talking to those who are experiencing symptoms themselves? So, and we really landed on the latter of that. So we're talking to people who know something isn't right, that have got something, that something's going on, and therefore for that audience, our sense was that because it's really about tipping them into action, and therefore it is about making them that message of making it very simple, making it very easy, and making it very like you're not just going to step into a kind of abyss. You know, there is hope here, there is a positive outcome, and to almost try and emulate what you'd hope the GP experience is and their treatment experiences in that soft, supportive messaging that goes through. I think if we were looking at a different condition, if we were looking at it at a different point in the journey, you might dial up or dial down. And the only other thing I'd say on that is the importance of that onward journey that Andy spoke about earlier, that I think if we had only been looking at the moment in which someone's, you know, engages with an ad, then you become very sort of one-dimensional and you're thinking about the campaign. Actually, what we looked at was, what are the moments that you have to think about, and the messaging you have to think about throughout that journey. When someone, you know, is Googling online, when someone is on a page on the site, when someone, you know, so I think my point is that I think it shifts and changes as you go through, and there's not really a one size fits all approach, really.
I'll just say on that as well, I think I obviously wasn't able to show you the film, but it takes a very case study led approach. So looking at individuals who have actually been through the process of going to screening. I think we were really conscious of that fear and that sort of skepticism about what is this, what will it involve. So the women that will be featured in that film that you just saw those photos of, they talk about how scared they were as well, and that they actually then went through the process. They were made to, you know, they were kind of reassured, they were comfortable, that the practitioner spoke to them about what was going to happen. And then this was kind of what happened afterwards. And so I think it's just that reality check, not saying, oh, it's fine, and sort of brushing it off and saying, don't worry. It's admitting that there is fear and there is a reason to be scared, but then trying to allay those fears through that kind of case study led approach where people can see themselves in those individuals. I think that really helped.
Great, thank you very much, Emily. I think we've probably only got time for one more question, possibly two. I've seen there's been a couple of people have posted sort of similar questions to do with the role of GPs and the availability of the fit tests. So I'll just come to one of those now, which is, could fit tests be made available by other healthcare professionals, for example, pharmacists, practice nurses? I think obviously, Joe, you talked about sort of at mammograms and things like that before as well. How else could fit tests potentially be made available, and, you know, would this make a difference? What would happen there? I think probably Andy, you're the obvious person to come to you on this one first of all.
Yeah, it's a question we've asked ourselves here as well, and how the role we could play potentially in helping to drive that. I mean, it's certainly an interesting model. It's a different pathway. There's a few things that obviously come to mind. One is that We need to make sure that there's the capacity to kind of manage those tests and do that referral well. Primary care still need to be involved, even if they're not the first ones kind of providing the fit. But it is really interesting, and to go back to Ian's bit earlier, you do it, but you would need still a behaviour change model to go alongside it, to let people know that they can go to their pharmacist and talk about this and receive something as a result, and get around that kind of not having to wait 4 weeks for an appointment or whatever it might be for them locally. But it's a really interesting idea. I think lots of people are starting to think about this, but we need to. It's a tricky balance to get that right, I think.
Ian, I think you're on mute.
Apologies. Yeah, I think the opportunity goes beyond fit tests here. I think one of the things that I referenced earlier that Christian von Wagner at UCL and I have been working on recently is trying to explore the role for other health professionals within primary care, particularly pharmacists, to be better supported to play a significant role. They already do play a role in making referrals to GPs. There's a national pilot that's taking place that's exploring whether they can have a role in directly making referrals to secondary care as well. But we think there's more that could be done to understand how to optimize that, how to make sure they've got the skills, the resources, the relationship with the GP, and that system is working well. And so I think that goes beyond just bowel cancer. There's opportunities there for other cancers where people will report to a pharmacy setting more easily because it's a high street environment, particularly in more deprived areas, particularly with some of the groups that are more underrepresented. The pharmacy setting offers a real opportunity if we can get that sort of intervention right.
And to add to that, Ian, I think as well, people are going to the pharmacy to self-manage symptoms. Exactly. To pick up easy over-the-counter medications. We did a project last year with Pharmacy in Wales, which is funded by the Moondance Foundation, that was looking at could we add in some trigger points for sort of around the right sorts of medications, your Imodiums, your hemorrhoid creams, etc., to spark off that thought about seeing the GP, and again skilling up pharmacists to be able to have those conversations as well. And again, in that case, it's speak to your GP if these symptoms are persistent. So there's lots of opportunity. I think that I did see a comment just now, and it's absolutely right that we mustn't forget that pharmacists don't have unlimited capacity either, and have similar problems. So
well, that's where it's about making it easier again, and that's where I think an intervention could be effective, is understanding how do you make that process as easy as possible for all concerned.
Absolutely. Well, thank you very much. I think that's given some really interesting food for thought. Sadly, I think we're going to have to sort of wrap up now. We've nearly come to the end of our session, but thank you to everyone for all your questions as well. There's been lots of really interesting engagement in the chat and the Q&A as well. So thank you to all of you. Thank you also to all of our panelists today. I think we've all learned a lot. I think it's been a really, really interesting discussion as well. I think we should have our LinkedIn and Twitter handles will be in the chat now, I think, as well. So if you've enjoyed our event, please do sign up to our Clare Mail, which is on our website. Follow us on Twitter, follow us on LinkedIn. As I said, the links for you should be there now. We send out Clare Mail, which is our newsletter, about every 1 to 2 months, and this is always the first place that you'll find out about our events and things that we're doing as well. So if you want to come to another one, please sign up to that. If you have any comments or any feedback about today's event as well, please do get in touch with us. The email address to send that to is hello@claremont.org.uk. So that's it for today. Thank you very much, everyone. Thank you for coming. Thank you for your questions. We hope to see you again soon, and goodbye for now.
Goodbye.
Bye.